So, good evening and a very warm welcome to all our audience. Thank you for being part of this webinar provided to you by EUROSPINE. Let me just start shortly by introducing EUROSPINE to you. EUROSPINE is the Spine Society of Europe. It's a professional, non-profit organization focused on the advancement of spine research and treatment. And it aims to be your all-in-one destination for everything around the spine. My name is Peter Völlig. I'm orthopedic spine surgeon from the Medical University of Graz in Austria. And I'm chair of the PatientLine committee, which organized this webinar for you tonight. PatientLine is part of EUROSPINE, and it aims to provide information for patients with spine conditions explained in a clear, reliable, and trustworthy way. It's available in several languages and can be easily found on the EUROSPINE webpage, as well as on social media. If you navigate to eurospine.org, just click on patients, and there you will find a lot of information around the spine. For example, you can find different information about areas of the spine where you might experience pain. You find different information about spinal conditions and also the recordings of our webinars. And all of that is available in several different languages. So I really want to invite you to also have look at our webpage. And now I hope you will have a very informative and interesting webinar, which is going to take place today during the Osteoporosis Awareness and Prevention Month. And I want to hand over to Leo Kronberger, who is also a member of PatientLine committee and is going to moderate this webinar.
It's a pleasure as well from my side to welcome you all on this great webinar with a great idea and a great topic. I'm going to share my screen right now. So we are going to talk today about fragile bones and strong care. So expert solutions for the spine fracture prevention for the Osteoporosis Awareness Month in May. I have no disclosures except my personal interest in several companies and my personal interest in several organizations to spread the idea of orthogeriatric care to my world and to the world around me. Starting with osteoporosis, it's a growing burden for society. It's a systemic skeletal disease characterized by low bone mass, deterioration of bone tissue, and a high risk of fractures. It's a so-called silent disease because there are often no symptoms until a fracture occurs, and fractures can happen even from minor falls or everyday movements. So what does that mean to the society? Over 23 million people are affected just in the European Union, and we have approximately 4.3 million fragility fractures which occur all over Europe, which leads to the loss of independence, disability, and as well to early death. The economic impact means a total cost of around close to 60 billion euro. And as you can see as well, the falls are associated with a decrease in quality adjusted life years. As well, already Lancet proposed in a study 2005 that the number of fragility fractures is going to rise and rise over the upcoming years. The problem is only 25% of women and 17% of men receive an appropriate osteoporosis treatment after fractures because it's most of the time underdiagnosed, undertreated, and underestimated. So the idea of this webinar today is to give you a closer idea of the disease, how it can be treated, how it can be detected, and how you can make a prevention by yourself. I'm more than happy to welcome two speakers. Firsthand, Sebastian Bigton, who is the Deputy Director of the Spine Surgery Department in Spital Emmental. He's an orthopedic surgeon with subspecialties in spine surgery and interventional medicine, and a member of the EUROSPINE, and a great teacher who were lucky enough to hear him at several possibilities. And on the other hand, I'm happy to welcome Upinder Sahota, who is a professor in orthogeriatric medicine and a consultant physician at the Nottingham University Hospital, and as well a scientific committee board member and chair for the vertebral fracture specialist interest group of the Fragility Fracture Global Network, where I'm as well part, at least, of the network, not of the special group. I just want to start with a small comic before handing over to the two speakers. It's like a typical picture. It's like an old patient just falling, having a pain in the lower back, and most of this patient, they just basically go back home. And what leads most of the time, it leads to a social isolation. So the idea, and this is why I personally love, besides spine surgery, the orthogeriatric medicine, it is a holistic care of for patients. And that leads me basically to my last slide, which is basically a good comment to the end. It's teamwork, which makes a dream work. And this interdisciplinary approach is basically what we're seeking for, which is basically the best for our patients. So as well, from my side, I'm going to guide you through. If you have any question, you can write them in the chat, and I will hand them over to the two speakers. And as already mentioned by Dr. Ferlich, you can find basically everything on the homepage of EUROSPINE. From my personal side, it's my first webinar organized in the PatientLine committee, and I want to thank as well Peter Ferlich personally for the opportunity to be part of the PatientLine committee. So I'm happy that Sebastian can start now with his talk.
So thank you very much for the nice introduction. Good evening to everyone. I want to share my perspective as a spine surgeon with a special interest in the osteoporotic fractures. So I have no disclosures regarding this talk, and I want to share with you, what does osteoporosis mean? What you can see here is a CT scan from a 40-year-old male patient, and you can see the vertebral bone in two slices, and compared to that, this is a 70-year-old female bone. Same slices, very different occurrence. You can see the trabecular structure within the vertebral bone is much more thin, which makes it more fragile. And what does it mean, osteoporosis in general? Osteoporosis is very well defined since 1994. This was the first definition by the WHO, and it meant that if you have a bone mineral density that is 2.5 below what was expected, this means you have an osteoporosis. Today, we know that there's much more to it. However, this was the first definition for that. And we can measure this with a bone mineral density scan, as you can see here as an example. And why is this relevant? This is very well investigated in Switzerland. If you have a 65-year-old man, the lifetime fracture risk to have an osteoporotic spine fracture is 20%. So 1 out of 5 men being 65 today will have an osteoporotic fracture during their life. When you look at women, it's a 50-year-old woman today will have 50% of those will have an osteoporotic fracture. And this can easily be avoided because we know the basic drug therapy can reduce the risk for a fracture with up to 50%. So prevention is the key. And when I see a patient, what's the natural course of the disease? What you can see here is an osteoporotic vertebral fracture. This is the original image from the publication in a very renowned internal medicine journal from 2001. And you can see this lady has a fracture. You can see the red arrows. 8 weeks later, she comes to the same practice, and you can see 2 more vertebral bodies have been fractured. Another 10 weeks, and the 4th vertebral body has a fracture. And from this publication, we know that the natural cause of the disease, if you have an osteoporotic vertebral fracture, is that in 20%, so 1 out of 5, there will be another vertebral fracture happening within a year. So there's a really high risk. It's not over when it starts. So again, prevention is the key. I looked at the data we had at our university. So I looked at 8,000 fractures and found that most of the fractures, they will present at the thoracolumbar junction. So where your thoracic spine meets your lumbar spine, this is the high infliction area. And most of the fractures, 60% of them, they will occur over there. And then we see that with growing age, there's a higher risk and a higher occurrence for osteoporotic fractures, peaked at 70 to 80 years. So that's just natural because our bone gets lower and lower and lower in density, and then the fractures will occur in advanced age. And then what I found very interesting is I looked into 10 years of data, and we saw that the rate of patients we did surgery on in between 2003 to 2012, and also beyond that, it decreased. So right now, it's about 50% of patients with osteoporotic fractures will receive surgery. This seems still like a high amount, but why is that? We know that osteoporotic fractures, they increase in frequency, still yet we are doing less and less surgery. And this is because we understand the osteoporotic fractures better. It's not every fracture needs surgery, but you have to look carefully and detect those patients that will benefit from surgery. And I'm going to go into that, what surgery means. But first of all, when I look at a fracture, I find this very handy. There is this OF classification published in 2018, and it gives me a nice overview about the severity of the injury. So in osteoporotic fracture classification 1, there's only edema in the MRI. This is a stable fracture. The patient will most likely have pain. That's true. However, surgery is usually not necessary. On the other hand of the spectrum, there's the OF5 injury. And this is something... Oh, can you still see my... damn it, I lost my screen. You can see me?
Yeah, we can see your
okay. Yeah, we can see you.
Thank you very much. I'm sorry, I lost the screen. So on the other end of the spectrum, there's the OF5 injury, where all columns of the spine are affected by the fracture. Those are very unstable and they need surgery. What does surgery mean? Usually, surgery in my hands is a very minor surgery. It's called kyphoplasty or vertebroplasty and is performed under local anesthesia. So no general anesthesia needed. You can only do this. Like in this patient, 70-year-old lady, she just went to get the newspaper. She bent down, lifted the newspaper, and she felt a crack in her lower back and proceeded to the emergency department. The emergency department did this CT scan, as you can see here. And at this level, you will see a deformity with a yellow dotted line. This is a regular vertebral body. The red dotted line is a fractured one. She wasn't able to stand properly under opiates, and you can see that the fracture is also compressing more during weight bearing. So what I did was I introduced some needles under local anesthesia into the bone. And you can see when she was lying on her belly, the fracture was more or less reduced already. And you can see there's still a small line, not perfectly anatomical, but I can increase this. I can do it better when I introduce a balloon and lift the fracture up to an anatomical position and then fill the bone with cement. And those are the X-rays after the cement augmentation. The procedure takes 15 to 20 minutes and is under local anesthesia. And to avoid certain risks, there is the possibility to do a vertebral body lavage. What you can do, you will get all the dangerous fatty tissue out of the vertebral body by doing a lavage, like pulling out the fatty tissue to avoid complications. So now, I told you and I showed you there is the OF classification that is very helpful and handy. However, I already also told you that not every patient needs surgery. And this is why I want to present you two cases that seem similar at first sight, but they're not. First of all, I present you an 80-year-old female patient. She came to my practice with atraumatic lower back pain. She was more or less compensated with her painkillers, with only low dosage of opioids. She has a known osteoporosis. And as you can see here, she has this OF2 fracture, so only a mild compression that is more or less stable when you see it in a full standing X-ray. So there's no compression. So what I recommended was physiotherapy, and I did a follow-up consultation after 1 and 6 weeks. I also, when I see a patient with an osteoporotic fractures, I always recommend doing a geriatric assessment. I'm coming back to that later. I usually don't give braces, and I proceed with analgesia, so the patient is comfort well. So the second patient, 80-year-old female, she was not, in the beginning, she was not referred to me. She was treated at another hospital. She also had atraumatic lower back pain, but slightly higher pain levels, and also a known osteoporosis. And the colleagues from the other hospital saw the fracture. You can see it's more or less benign and very similar to the fracture I showed you before. It's also an OF2 fracture. And the colleagues recommended conservative therapy and said, that will be fine. But it's not. This was the patient after she was referred to me. You can see from a relatively benign fracture, from an OF2 fracture, the fracture progressed to a complex fracture with a complete disruption of the vertebral body frame. So a high kyphosis, very dangerous and severe fracture at that point. So what I did was I did the percutaneous screw fixation. I was able to correct the spine. I was very happy with the result, but still, this is a surgery that takes about 45 minutes to an hour, and it requires general anesthesia. So it's a little larger than what I showed you before. So why is the one OF2 fracture different from the other OF2 fracture? And it's just because the patients are not the same. So if you look at this patient, the morphology is benign. The bone mineral density was quite good, actually. The deformity was not progressing, and the pain was bearable. No neurologic impairment, and the patient could be mobilized. So relatively benign fracture, and the patient was more or less healthy. On the other hand, you see the bone mineral density is way lower, so there's a higher risk for the fracture to compress. We don't know if the deformity is already progressing because in this case, our colleagues did not choose to do a full standing X-ray to compare to the lying CT. The pain was not controlled. The mobilization was not too good. When I asked the patient, she said she was lying in bed most of the time for the 6 weeks, and the family was taking care of her. However, she was not mobile at all during that time. And what do we do now? So is this what we are doing evidence-based? And yes, it is. There was a very popular study in 2010 published in a high-ranked journal, The Lancet, and it included 21 centers in 8 countries with 300 patients equally allocated to a group receiving surgery and non-surgical treatment. So what you can see here in this graph, the pain graph on the left side, the dotted line is the conservative treatment group. So even at 12 months after the fracture incident, patients receiving surgery had lower thresholds for pain than those not receiving surgery. Also, opioid use is not statistically significant after a year, but patients receiving surgery had significantly less need for opioids in this study. This is a prospective randomized controlled trial called the VERTUS study. And what we know from a registry study from Scandinavia with more than 4 million people included, at 4 years follow-up, patients receiving surgery for osteoporotic vertebral fractures have a significantly lower mortality. We don't fully understand why this is. However, we see a statistically significant difference. So taking all of that into account, what is my algorithm to treat patients with an osteoporotic fracture? I don't treat only the patient and the fracture. I always recommend a geriatric assessment. We have a good fracture liaison service, so every patient will see a geriatrist. I will not perform, but I will recommend drug therapy in every patient because I know the rate in adjacent fractures is lower. And I will prescribe physiotherapy and with a special algorithm. So what does geriatric assessment mean? I'm not going to go into too much into detail, but you have to look at the patient and you have to advise him look for tripping hazards at home. Is there any risk for falls? Do you have to wear glasses or adjust them? Is there sarcopenia present? Is the muscle strength enough? And obviously also laboratory markers and the drug therapy. Physiotherapy, and I apologize, I only have it in German, is usually divided into a load unstable phase. So for the first 6 weeks, I advise my patients not to lift too much weight, be very careful with mobilizing. Mobilization should be like with the back hygiene. So your shoulders and your hips should be in line most of the time, but you still can do some exercises. And we give this recommendation to our patients and the physiotherapists around, so everyone can read it and follow it. After that, we have the load stable phase. So after the fracture is healed, more or less, you can increase the load up to like very sport-specific loads as well. So to conclude, every patient has to be assessed as a whole. There's no patient like the other. Osteoporotic fractures are an animal that can develop and progress very quickly. So you need follow-up consultation up to 6 weeks in my practice to be sure that the fracture remains stable. The OF score and the OF classification, and you can read this also in the internet, and there are also videos for that, are very helpful to determine if a lesion is stable or not stable. And you can advise the patient preferably with the score and the classification. if surgery is necessary, I prefer minimally invasive surgery, and I prefer to do it only in local anesthesia. And in the end, we need not to treat only the fracture, we need to treat the patient. We have to look at the patient's needs, look at bone quality, look at the whole thing. And so we can make an informed consent with our patients. I thank you very much for the attention, and I'll hand over to Opinder.
Thank you very much, Sebastian, and good evening, everybody. Just get my slides. So it's a pleasure to share with you for this evening's slot, and thank you both to our speakers for their kind introduction, and obviously sharing the pathway of really managing acute vertebral fractures. Thank you also to PatientLine at EUROSPINE for the opportunity to share with you and hopefully make you all experts within the osteoporosis field. My talk over the next 20 minutes will really be a very practical and a pragmatic talk, and hopefully give you some tools that you can take back to your specialists and challenge them for tests that you should have done and for treatment that you should have, and really what's recognized as really best practice to try and help our patients. As we've heard from both of our speakers, that osteoporosis is a condition which affects the whole spine, leading to weakening of the bone. Osteoporosis does not cause pain unless you fracture, hence the term the silent epidemic. And obviously, fractures that are the most common fractures are those fractures that we see of the spine, the wrist, and the hip, but other fractures can also occur as well of the pelvis, the arm, and the leg. So the real important issue is that if you've had a low trauma fracture, and by low trauma we mean a fall from a standing height or less, and broken a major bone, then clearly we need to assess for underlying osteoporosis and further treatment, clearly if the test confirms this. There's lots of risk factors. I put a big list here, and it's just an exhaustive list, but I do welcome you to go back to the website, which is a really great website and has lots of information on this here. We know that unfortunately, the factor that determines your biggest risk is your genetic makeup, and up to 60% is from your gene makeup. And often we have many patients who come to us and say, "Oh, doctor, I'm really good, I'm really healthy, I don't drink, I don't smoke, I exercise, and I've got osteoporosis." And yet I know somebody who drinks lots, smokes lots, and they're fine. And because genetic makeup plays the biggest risk factors. 30 to 40% is from other factors, and they may be affected by our diet and lifestyle, different hormone levels, and those may be perhaps things that we can modify a little bit and take into our own hands. There are also medical conditions that can exacerbate bone loss. And again, the physician that you're looking after you hopefully will be aware of these issues. For example, commonly you may have conditions which require steroids. And we know that actually the steroids will help the underlying problem, but the steroids themselves have side effects, which then can lead to bone loss and osteoporosis fractures. There's a whole list of other medication that are also there. And it's important not to stop this medication, but to seek medical advice by the specialist that's looking after you, because there's an increased risk of osteoporosis with these medicines. And often we have to use osteoporosis medication alongside these other medicines to try and help you. We've heard about the bone density scan. This is the default way to assess the strength of your bone. We can look at the x-rays, and we can look at possibly and comment on sort of the x-rays where the bones can look what we call osteopenic, and the bones look quite thin, but really the dual x-ray absorptiometry scanner is really the way to assess the bone density. In many units now, as well as assessing the hip and spine strength, we also ask patients to lie on the side, and we can also look at the whole spine as well. And this is a technique called spinal morphometry. And for many patients who may not be aware, you can have vertebral fractures, but then imaging allows you to actually pick up these fractures. There's a tool that you can use, so all of you can go after the talk, can go online and you can Google in what we call FRAX. FRAX is what we call a risk assessment tool. You can put various things in, looking at your risk factors, and it has various things: sex, height, weight, previous fracture, any other risk factors. And if you have a bone density scan, you can put those numbers in, or you can put in your risk factors and say, well, do I need to have a bone density scan? And we often ask our GPs to sort of use these tools and look at these tools. For FRAX within the UK, what we have is a system that you have on here. You put all the risk factors and you press this switch here called calculate, and then calculate pulls up a nice graph as shown here, which then will tell usually the primary care doctor that a patient will fall into one of three groups. Within the green group, where they can be reassured for lifestyle and advice, in the amber group, where they need to have a bone density scan, or in the red group, where clearly they are very high risk of future fractures and need to have osteoporosis treatment. So it's a really, really simple tool, and patients can even use this, but really we would recommend primary care doctors have a discussion with your GPs. They can help you enter the risk factors for you. And then clearly if you need to have a scan, then this is good evidence that the scan is recommended, or if treatment is really necessary. So what are the treatment options that we can look at to help? So if you've had a fracture or risk having a fracture, I so often used to jest and say, well, actually, wouldn't it be really good if we had something like an airbag? You know, if you fall over and an airbag pops up and stops you breaking bones. And I used to jest for this for many years back. And this was some of the early prototypes going back probably about 9-10 years ago now. This was a photograph for one of the national papers, and this was some early research work, and this was the airbag jacket. And as you can see, when you fall over, there's a big bag that pops up the back of the head and two bags that pop up the side of the hip. So very much like when you're in a car and you have an accident, an airbag pops up and cushions the body. And lo and behold, we now have licensed devices. So this is one of the European airbags, and it's now commercially available. And this is one company that make airbags, particularly for sports, so cyclists and equestrian sports, motorcyclists. But now this is one for patients. It's a belt that you just strap on around the waist. It has what we call a triaxial accelerometer in it, and when it recognizes if the body's falling over, and all of a sudden an airbag will actually pop out. And there's also an airbag jacket that's now also commercially available. So again, I think the future is very exciting, particularly for some of our very frail older patients where perhaps they're really struggling to mobilize and high risk of falling. I think this is going to be really quite exciting in terms of the future, looking at garments to help protect the body and hopefully keep us away from the surgeons. Things that are really important that we've got to do is the smoking and the alcohol. We know that the nicotine from the cigarettes directly slows down the cells that make bones. These are the cells called the osteoblasts, and smoking actually inhibits these cells, and therefore the cells can't work properly. Secondly, we know that alcohol, and certainly too much alcohol, poisons the liver. And again, the important cells that are there to help, again, develop bone and make bone, these also are affected too. So clearly, smoking and alcohol, cutting back, and certainly stopping smoking is really clearly important to help maintain and improve bone strength. Exercise. Everybody talks about exercise and said, oh, and had a few patients this afternoon saying, well, I've joined a gym. To me, exercise is really about the motivation of doing something regularly and something that you enjoy, rather than paying lots of money by joining a gym. And what we often say that if you can combine the exercise where you can effectively have 20 to 30 minutes, at least 3 times a week, of, for example, brisk walking, as well as the bone benefits, you also get the cardiovascular gains as well. So really, really important, really, from that point of view. Keep active and keep moving. I can't stress that enough. Again, there's lots of things around the house. You can take two sugar bags or two soup tins, and even simple exercises in the house that you can do. We all have stairs. You can practice safely holding the stair rails and practice just walking up and down one step, down a step, just regularly 2, 3 times a day. So very, very simple things that you can do even around the house rather than having to go out to these expensive places and paying for these expensive gym sessions. Vitamin D and calcium is really, really important. We know it's a real challenge, particularly for vitamin D, where we know certainly across the climate that there's a real problem in terms of access to vitamin D. Most of the vitamin D we'll make from sunshine, and it's really important to try and get as much as sunshine within reason. And there's a real balance between the risks of skin cancer and obviously getting enough of the vitamin D. And what we would recommend as a safe option is, if you can, it's semi-exposure, so arms up to the mid shoulders, the face, head, from March all the way through October, at least 10-15 minutes a day is reasonably safe without putting on a sunblock. And that should help get the vitamin D levels that you need. But clearly that needs to be balanced against the side effects of being in the sun for too long and the risks of skin cancer. And we know that if you get vitamin D right, then the calcium that you take from the diet will be absorbed effectively. So that's the really most important part. And what I've done here is just put down milk and how much calcium is in milk. And what we often think that actually full skim might be better, but when you skim off the fat, yes, you will have more calcium in, but I don't know about many of you within the audience, but I'm not a fan of full skimmed milk. I think it tastes vile. So I think semi-skimmed milk is a reasonable compromise to have, and it has enough of and it has reasonable amounts of calcium. And then you can take obviously the vitamin D, either exposure or just take a supplement, which will often help you. In our routine practice, this is what we routinely recommend for our patients that come to our clinical care. We recommend optimizing dietary intake from calcium. So we try to avoid calcium supplementation in the very early stages. We give them a dietary advice, give them food charts where they can go and look at what types of calcium that you can get. And then you'll find that there's many products that have calcium in, and you can easily quite supplement your diet from there. Clearly, where you're struggling to manage, there's some really cheap over-the-counter preparations that one can go and buy from the supermarket. There's no need to buy these expensive preparations. But again, from over the supermarket, they're reasonable and to reasonable costs. Clearly, where we are worried about and we're giving more specialist treatments, that's drugs like the bisphosphonates, particularly intravenous medication or medication where we're using bone building medicine, then it's important that the vitamin D levels are optimum. And for many of those patients, we may give what we call a vitamin D blast or a boost over 6 to 8 weeks. So really quite a big, large dose, and then put them onto a regular maintenance tablet, which they can often take. And then really as a last resort for our patients who are struggling to maintain their dietary intake of both vitamin D and calcium, then we would give them a combined supplement. Because these combined supplements, we've moved further down the list because they can be quite difficult to take. They're often quite big tablets or quite difficult to chew, difficult to swallow. So really as a last resort where you've exhausted all of the steps above. So there's lots of treatments now, and there's no excuse. So clearly, if your specialist recommends an osteoporosis treatment, but you're struggling with the treatment, then obviously you need to go back to your specialist. And we see so many patients where treatment is recommended and they've stopped and said, oh, well, I've not been able to take this tablet or this medicine. Nobody spoke to me about other things, but there's really other medicines that you can take. And we divide medicines into really 2 types of medicines. Medicines that slow your losing bone, and these are called the anti-resorptive agents. These are on the left. And we have what we call bone building medicine. This is the anabolic medicines, and that's on the right here. And again, some of you within the audience may be on various medications per se. And there's lots of guidance, and I'm not going to go into this slide in any detail, but the important thing to remember is really two things I really want to highlight from this slide. That clearly, if you can't take medicine, it's really important to then seek advice. And clearly, it's important when you are prescribed medicine that you continue with the medicines, because clearly, if you don't take them, they're not going to work. And if you don't take them, we know that fracture risk then will increase, and that risk can increase quite quickly. And these are just more of the pictorial types of diagrams of some of the medicines that you may be taking. So these are what we call the bisphosphonate tablets, and these are often recommended to be taken, at least they are routinely recommended to be taken once a week. They have to be taken fasting, so when you wake up first thing in the morning, they have to be taken upright, and then a glass of water to wash the medicine down, and then nothing to eat or drink for at least half an hour to 40 minutes. And the once a week one are the alendronate and the residronate, and the abandronate is given as a once a week. Another type of medicine which we use perhaps more commonly is the big brother of the previous medicines, called zoledronate, and this is given as an infusion, and so it's a little drip. It takes about 20 minutes to infuse into the body, and we tend to give the infusion either once every year to once every 18 months, and certainly for compliance it's really helped. And this is perhaps being used more and more often now, particularly across Europe, essentially because it's a lot easier than to administer, and also the cost of this has come down considerably over the last few years. Another type of medicine is denosumab. This is given as a subcutaneous injection, and this can also be given, for example, like a flu jab. So this is given twice a year, and some patients will have a flu jab once a year plus this medicine, and then another dose 6 months after. And again, treatment which is ongoing. The only really important fact with this treatment is that once you start it, you cannot stop this medicine, because there's evidence to show that if you are on this treatment and you stop it, of 6 to 12 months after, your fracture risk goes up and could actually cause more problems. So it's important once you start this, effectively it becomes lifelong treatment. There are some really rare side effects, and I'm mentioning these because every time we talk about these medicines that I've just shown you, everybody says, oh gosh, these cause problems and side effects. And again, with all medicines there are side effects, and this has to be balanced against the benefits of the actual treatment itself. One of the rare side effects is what we call osteonecrosis of the jaw, or ONJ. So essentially, when tooth is extracted, bone will take a long time to heal. And again, this is a very rare side effect, but when you go and visit the dentist, they often get very anxious, and it needs to be shown there. And so clearly what we would recommend for patients before starting treatment to really have a dental check, and where dental treatment is planned, perhaps have the dental treatment first and then start you on the medication. Another also very rare risk is this, what we call this association, not a cause, but an association. There's some evidence to show that patients who are on long-term bisphosphonates, and particularly the intravenous medicines that I mentioned, there may be an increased risk of what we call these funny fractures across the femur. This is the leg bone here, as you can see here, and across the middle bit of the leg bone, they can have these rare fractures as well. And again, these are extremely rare, but I've mentioned them because these are often talked about in terms of the media, and certainly journals like to pick these things up. The anabolic therapies, these are the bone building medicines, and really given a little bit like insulin. So this is a daily injection, which you grab some skin, inject the needle into this, and inject the medicine in. And it's given as a daily injection every day for 24 months. This is one type. And then more recently, another type of medicine called romosozumab. And this is a 12-month course for which 2 injections are given once every month. Again, this is bone building medicine. And we're now seeing perhaps a real change in the culture of managing osteoporosis now across Europe, where perhaps bone building medicine is starting to be used first and then bone slowing medicine after. And a lot of that is also because I think the cost, but also the evidence is showing that this is much, much better. And clearly, where you have multiple spine fractures, you really want the strong medicine first to build the bone up. Then it makes sense then to have the anti-resorptives to maintain the bone. And so this is perhaps where we're seeing a real change across Europe now with new guidance and recommendations coming forward. And third line, I've just listed this drug here. It's still a medication. This was a medication that was developed on the backbone of the anti-breast cancer medicine. This is what we call a SERM. A SERM is a selective estrogen receptor modulator drug. And it's a drug that's been here for a long, long time, and we kind of forget this. But it has, again, some very good data for helping bone and also for anti-breast medicine, particularly for women who have first-degree family relatives at high risk of breast cancer. And again, it's another medicine that you can use. And again, your specialist may be able to guide you where it may be appropriate for this medicine. Okay, so hopefully just taking you through a walkthrough of the basic tests that we can do, the lifestyle things that we should be thinking about, and most importantly, the different types of medicines that we can have and where you should seek advice if you're struggling with your medication. Thank you very much.
Thanks for the great talk of both of you guys. The first question at the question and answer was already directly answered by Sebastian. So feel free to ask question. I could give them towards the two. So from my point of view, I just want to first having a question to Sebastian from a patient's perspective. You were firstly talking about that you try to basically do everything in a local anesthesia. I guess a few patients have concerns about that because they have to be on the belly side. So from a patient's perspective, what are you explaining to them, like how you're trying to take a bit away the fear of the patients towards that topic?
Mm-hmm. Usually patients are more afraid for the general anesthesia, and local anesthesia is usually very well accepted. And we have a standard operational procedure with our anesthesiologists. They will give some light medication so the patient can sleep only a little bit. And I do the local anesthetics as an adjunct. And so there's no general anesthesia necessary, and most of the patients appreciate this. So when I usually tell them it's feasible in local anesthesia, most of them will like this idea very much.
And just one point about the conservative treatment, is the way you're doing that, like, are you doing the X-ray controls and checkups? And what is your opinion about the orthesis for the spine? Are you using them? What is your personal opinion towards the orthesis?
I don't like the bracing too much, and there is not enough data supporting that bracing is beneficial. I think it's more important that patients can be mobile on their own. If I brace, if I do an external bracing, my muscle tissue will automatically decrease because it's not necessary at the moment, and then I will have trouble to get away from the bracing. So usually I advise my patients with a special physiotherapist plan to, like, in a non-load bearing environment, do some back hygiene, mild physiotherapy to have an activity, but not too much.
Okay. We have one question to Dr. Zahota from Marcelo Rodriguez. He's asking you about the drug holiday in the bisphosphonate therapy. What is your opinion about it?
Yeah, so thank you very much, Marcelo. That's a really good question. So yeah, so what routinely recommendation is when you're on the oral tablet, the alendronate, routine is normally to give it for 5 years and then to assess what's happening with the bone. And then if you're having the intravenous medication, that is the bisphosphonate drip, then usually after the 3 years. And what's really important is the assessment. And we've seen, particularly within the UK, a lot of the primary care doctors think after that time we should stop the treatment. But what's really most important is the assessment of the patient, okay? And so for some patients, after that assessment, the assessment will be clearly seeing how the patient's managing and how they're doing. You may get an up-to-date scan, you may get up-to-date further imaging. And for some patients, it may be to say, right, okay, then maybe it's sensible to have a drug holiday because they've been well, the bone density's gained, they've had no fractures, and that may be sensible to leave them off treatment for just a few years. However, for some patients who may have continued to fracture or remain at high risk, you may either continue with treatment or switch treatment. So the most important thing is the reassessment. It's not just stop treatment automatically. And really, if there is a planned drug holiday, there should be a planned follow-up for that patient as well. And time again, we've seen many, particularly primary care physicians, stopping the medication, saying, "Oh, you've had the 5 years. Stop now." That's a wrong answer. The answer should be assess the patient, and then clearly for some, you may want to stop.
Thanks. And there are another two questions. One question is, in case of deformity surgery for an osteoporotic patient, do you recommend any drug preoperatively? And on the other hand, is there a time that you want to start the medication? And so how much time in advance to the operation?
Sure. So no, again, that's a really good question and something. So in Nottingham, we have a joint, we run this regional spinal unit, and it's a big issue that with everybody we talk about the bone density, we look at what we call the Houseville units. You can look from the CT, it tells you how strong or weak the bone is. Or for my colleagues in spinal services who are seeing people electively, that is in the routine clinic, and they're worried about the bone strength. For sure, it makes sense to build up the bone, and that's the way I think the future will start moving, is to say, can we? And it makes sense that for a surgeon, you want the strongest bone possible to put screws and plates in. You don't want to put screws and plates into cheese that then just really comes out. So unfortunately, at this present time, there is no medication licensed for the preoperative bone building. But clearly a way around often this is that if you do an osteoporosis assessment, and if the patient has osteoporotic bone, as part of their osteoporosis treatment, then you can give these patients a medication. And my usual time interval, particularly if they have very severe osteoporosis, I try to ask my surgeon, if possible, they can wait for at least 3 months minimum to try and give them the anabolic before they want to consider surgery. But again, the surgeon, and again, both yourself, Leon, and Sebastian may wish to comment, that even then, the surgery often you might use cemented screws, and you might think about a longer implant structure and all these things, because operating on an osteoporotic bone is extremely difficult and leads to lots of complications.
Yeah, the most important challenge, sorry, Leo, just as an adjunct to open you answered perfectly. Same situation here in Switzerland. There is no drug that we can prescribe as a preoperative treatment to increase bone strength. This is really an issue. Usually we try to send the patient to an osteoporotic fracture osteoporosis service to assess the bone quality, to assess if there are possible reasons for the low bone quality, and like to give vitamin D, do whatever we can, and try to bargain with the insurance company to tell, yeah, it's okay to give osteoanabolic treatment, but because this is what we ultimately need. And this is sometimes very difficult because we have to balance the patient's interests to the possible outcome of the surgery. Obviously, it's better when the bone is stronger, so we can have a shorter construct, we can do less cementation. Ultimately, we have to balance those things.
We have one more question by Mr. Eitel. He's asking, Upinder, what's your recommendation for the Movimia pen, for the teriparatid injection pen?
For sure. So perhaps within the UK, I suppose we're lucky in the way for our patients that patients have access to anabolic treatment, for free. There's not really an issue. There's not insurance difficulties, and there's not problems, from that point of view. But on the negative side, we're then limited to using the cheapest option. So that's where we have really difficult from there. So from my experience, the Movimiva was one of the biosimilar products that came across within the UK, and the Movimiva pen was used, and we had no choice, so our patients had to use this. Personally, I didn't like the Movimiva pen because, for those of you who are not aware, but it's one pen for the whole course, and every month you have to change the cartridge yourself and then prime the cartridge. And particularly for some of our older patients who don't have the manual dexterity to do this, it was quite difficult, particularly to prime the pen. We've now moved across to Sondel Bay, which is another biosimilar, which is cheaper, and I much prefer the Sondel Bay pen because it's just like the Lily pen. Each pen is preloaded each month, so every month you throw it away and you get a new pen, and so that's my preference. I don't know what the rest experience around Europe is, but I think this is a real problem that often, particularly in the UK, that the pharmacy prescribing advisors don't think about the patient as much. It's very driven by cost, and they don't think about the devices that they're using or how they're using. But I'm much happier with the new device that we have. It's much user friendly. I don't know if anybody else in the panel wants to share their experiences with their pens or wants to add to that discussion.
Thanks. I have one last question from my personal side to both of you. It's like we have, for all this prevention, we have for the prostate cancer, we have the Movember, we have the breast cancer month, now we have the osteoporosis awareness month. But about breast cancer and prostate, like, people are basically more and more taught that they should go for prevention, they should go to the urologist, they should go to the gynecologist. Women tend to do more prevention according to that. What is both of your thoughts about that for osteoporosis, and it's going to increase more and more, like Sebastian just said before the meeting started, like 500% till 2050, I think you said, the osteoporotic fractures will increase in Europe, or just except in Germany. Do you think there should be, like, from a certain age, like a kind of, at least doing the FRAC score with the family practitioner? Should there be done something else that people get to more in touch with that disease?
Yeah, so again, we probably need a whole lecture to give this talk. Where do we start? Because I don't think it's a whole public health issue, isn't it? The policy, it starts from the very young age. In terms of screening, I'm aware that the US are looking at a screening program at the age of 65. And again, it might be that that's perhaps where we move within the UK, that a screening program for 65 years and over and 50 and over in those at high risk groups, I think might be the way forward. I think the other big group is really education amongst healthcare specialists as well. We have many, particularly of our colleagues now, we're using a lot of oncology medication, we're using lots of steroids, we're using a lot more immunosuppressants, we're using lots of more of the biologics which affect bone. So again, I think there's both an awareness also about the public, about public health and education around general health and well-being, but also I think amongst healthcare specialists as well, who are treating these patients who are at risk, that need to be thinking about the bone as well.
Yeah, I totally agree at this point. especially what most of my colleagues don't know, pantoprazole, so a very common drug that is taken for stomach ache, and also often in combination with painkillers, that can cause osteoporosis because it's not only affecting the stomach, it also affects the bones. So if you're taking this for a long period of time, you have a higher risk for osteoporosis. So what I do in my daily life is I do my best to educate my peers, but the peers and the patients about the medication, about the risk of osteoporosis. And there are not really screening protocols established in Switzerland. However, you can propose a diagnosis if you have an osteoporosis-associated fracture, and then you can get the patients into the fracture liaison service and to have like specialized physicians look at the bone mineral density, look at reversible factors for osteoporosis. So I think it would be good for the society to be more aware about osteoporosis. And what we all can do in our families, in our practices, like to spread the word, to look at risk factors, to take a water that has high calcium, for example. So there are a lot of things we can do. Public screening, I think we're very far from that in Switzerland.
But I think what you said is like is a good ending for this session. Like we first have to look around our own families and spread it there, and then hopefully it gets wider and wider. And I think that this meeting was a great opportunity for those who are interested to get an idea of osteoporosis and fragility fractures. This for those who are interested, like and know people who couldn't attend today. It was recorded and it's going to be on the YouTube channel. And again, if there are any questions coming into your mind or from friends, I would assume that getting in contact via mail with one of the speakers or with us via EUROSPINE. So from my point of view, thanks a lot. I don't know if the boss, Dr. Felic, has to say anything else, or if we could say goodnight to everyone.
I agree, Leo. It was thanks to the speakers. It was a great and interesting talks. And really, please be aware of osteoporosis and try to prevent it. And lifestyle measures are probably the first step, which everyone can undertake. And I think that's a very important message we want to send out. Thank you.
Thanks a lot. Have a good evening.
Bye.